Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you are using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows towards the end of the presentation. American Sign Language interpreters and closed captioning options will be available for today's event. The American Sign Language interpreters for today will be Danette Stillman-Bridges and Susan King-Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the View feature located in the top right-hand corner of your screen and select the view that works for you. Today's agenda topics include introductions, department priorities, introduction to the Division of Mental Health, Developmental Disabilities, and Substance Use Services Executive Leadership Team, the State Mental Health Substance Use, Intellectual Development Disabilities, Traumatic Brain Injury Plan, our budget priorities and legislative updates, the local management entity Managed Care, organization dashboard, resources, and time for questions and answers. At this time, I would like to turn it over to Kelly Crosby, Director for the Division of Mental Health, Disabilities, and Substance Use Services.
Thank you so much, Vidya, and thanks everyone for coming today. Looks like we have a really good turnout, and I'm really appreciative that folks are coming. Today is the first in our reimagined webinar series. We're going to talk a little bit about how we envision these webinar series working in a bit. But I tell you it's our first to say we might have some bumps along the way. So bear with us, and in the spirit of continuous quality improvement, we're going to see how things go today and in the next few webinars, and we'll change things up as we need to. But really delighted that you joined us here today and very excited for this webinar series. So let me introduce you to myself a little bit. Vidya went through the agenda for today, and we wanted to use today kind of as a framing conversation. We wanted to make sure that you knew who we were at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. And we wanted to lay out some of the departmental priorities, some of our budget priorities, and talk with you about some statewide strategic planning that we'd like to engage with you in. And finally, as Vidya said, we wanted to show you some of the key metrics from our system that we are tracking. We want to share with you to talk about the health of our system right now, our mental health, substance use, IDD, and TBI systems. But before all that, let me introduce myself. My name is Kelly Crosby, and I'm a licensed clinical social worker. I always tell folks three things about myself. I am a mom because I love being a mom. It's really cool. I am a social worker, and I am a person with lived experience. I've been in this field for about 27 years. I've been at DHHS for about 12, most of those spent in Medicaid. So that's my second family and my second home. But I've been with the Division of Mental Health, Developmental Disabilities, and Substance Use Services since December of 2022. And I'm so happy to be here with this group of very passionate and dedicated folks. I've been a licensed clinical social worker, shout out to social workers, for a very long time. I'm really proud of that. I think of myself as a policy person, but also as an advocate. And like I said, I'm a person with lived experience. So this job means a lot to me personally. I have a lot of mental health issues, substance use, even suicide, unfortunately, in my family. So this is very personal to me. I put a few quotes on the bottom because I think as an advocate, I think it's really, really important that we all get really comfortable talking about mental health, that we talk about recovery as a lifelong process without stigma, without shame, and that we embrace a really inclusive world with people of all abilities. So I'm really excited about that. I'm excited about that as a division. And I'm excited about this webinar series. We called it Side by Side for a reason. We toyed about with many names, right? We wanted to come up with the right name, but Side by Side felt right because side by side is the way that we want to do this. We're all in this system together and we need to build it side by side. So we're envisioning this as a really collaborative space with you all. So again, very grateful for you all being with us today. I'm going to start at the very, very top, and I want to remind folks on the next slide of our departmental priorities. Oh, I think I already said this, but before I do the departmental priorities, you want to go back to that slide, my fault. So I already mentioned side by side and why we picked the name, but here's a little diagram for how we envision these working. So side by side is our monthly webinar series, and it's for everyone. It's for consumers, it's for providers, it's for associations, it's for LME-MCOs, it's for our sister divisions. So our sister divisions will absolutely speak with us like they always do. Medicaid, of course, Division of Child and Family Wellbeing, our colleagues at DHSR. So this is a platform for all of us who have shared responsibility in the system to meet together. But after this webinar, which is going to be really high level, we'll try to answer as many questions as we can, but it really is high level. We envision taking these topics down to our very strategic community meeting spaces. So we might introduce a topic here, but we look forward to breaking it down and talking about it more in our monthly provider meetings. We have a monthly provider and provider association meeting. We have our monthly state consumer and family advisory committee. So we would take those topics there. And we also have a monthly LME-MCO clinical leadership meeting. So again, we hope this space is a place to introduce joint priorities and joint ideas, but then to take those ideas to smaller settings for discussion, unpacking, solutioning in those smaller, more specific spaces. All right, next slide. So now I'm going to go back up to talking about departmental priorities. So you probably have seen these departmental priorities many times before, but they're really important. So when we think about our division's priorities, they come from the top. I think you all know that the department, DHHS, is very committed to a strong and resilient behavioral health system. But these are our departmental priorities that we've been working on for several years now with strategic projects. So the first is behavioral health and resilience. So we have a variety of projects that we've been working on to help grow stronger together after the public health emergency and to build a stronger system in this time of real behavioral health need and behavioral health crisis. We are jointly as a department focusing on child and family well-being, and there's a lot of behavioral health in that space as well. So mental health and substance use prevention and treatment for children and families, also support for families with children with IDD and autism and TBI. So there's a lot of initiatives in that space. And lastly, a strong and inclusive workforce. We know that we're all struggling with mental health, substance use, direct support professional workforce. And so that is a priority for us as a department, including how we strengthen the workforces in our field. So I just wanted to remind folks and kind of ground us. So whatever we do here is going to be grounded in those three large priorities of our department. They resonate really well with us. They're all areas that really matter to our system. So just wanted to ground us in those. And in a few minutes, I'm actually going to talk about our early strategic planning here in mental health, substance use, IDD, and TBI. And you will see how they feed back up into these departmental priorities. Next slide. So now I'm going to turn things over to the rest of our executive leadership team, but let me explain why. Like why are we going through introducing you to the team? We think it's really, really important that we have the most accessible system we can, right? And I think we have a lot of work to do, to be honest. Our system is not always easy. It's not always accessible. Despite our best efforts, it's not like we're not trying, but part of that accessibility too means you need to know who we are. So we wanted to have a space where we could introduce ourselves to you. We could introduce the areas that our leadership team covers. We wanted to introduce some key email and phone numbers and websites, so you would know who to reach, how to reach us if you needed specific items. So I'm going to turn things over to our executive leadership team so they can introduce themselves and their portfolios.
Hi, everyone. Good afternoon. I'm Renee Rader, and I'm the Deputy Director and Chief Operating Officer here at DMHDD SUS. A little bit about me. I have been in the field for over 30 years now. I've been with the Department of Health and Human Services for about 13 years. And I have been in my current position for about 8 months. My role here is really 4 things that I do. One is I support Director Crosby with day-to-day operations and long-term projects. So I am here to support her in whatever she needs me to do. I also lead the executive leadership team, the folks who are about to introduce themselves to execute the mission and vision of our organization. I also oversee the business strategy and operations. So that is everything that goes on behind the scenes. So that is from budget and finance to contracts to making sure that our building is maintained, anything that supports our internal operations. And then I also develop and manage processes here, our internal policies, and any procedures that we may have. And I am actually going to introduce Sarah Waleed. She is not here today, but Sarah is our Assistant Director for Policy and Programs. So she is all things clinical here at the Division of Mental Health, Developmental Disabilities, and Substance Use Services. She is over the entire portfolio of clinical policies and programs. So that includes mental health and crisis. It includes intellectual and developmental disabilities, traumatic brain injury, substance use disorders, including opioid use disorders, problem gambling, justice, primary prevention. I'm sure we're leaving a few off of here. We've added a few key contacts on this slide as well. So if you need to reach the Suicide and Crisis Lifeline, of course, you can always call or send a text or chat to 988. And then we've also included some links here for finding treatment in your area and a link to where you can submit questions that you might have to our division.
All right, thank you, Renee. Howdy, folks. My name is Charles Rousseau. I am the Acting Director of Strategy and Planning for the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I'm so glad that we have all of y'all here today. Really excited about this meeting. Like Kelly, I'm someone with lived experience, and I bring a lot of passion to this work because of that. I've got about 5 years of experience in the department, but one of the things I did prior to that, I was a direct support professional working in community settings with folks who have intellectual and/or developmental disabilities. And the importance of that work is one of the things that has brought me to the department. And I am thrilled now to be with DMHDDSUS, Division of Mental Health, Developmental Disabilities, and Substance Use Services. You're going to hear us saying the acronym out loud a lot because every part of that matters. And we also know that our traumatic brain injury or TBI work also matters. So think of that as essential. It's not in the acronym yet, but it is never forgotten. We are in this moment of historic need and historic opportunity. And so the strategy and planning section is new to the division. And part of what we are here to do is to coordinate the division's strategic planning efforts that will produce our state plan, which Kelly will talk a little bit more about in a minute. In my shop, we also do communications. So we are overseeing 2 communications campaigns that are just beginning to be developed. One is an accessible communications campaign so that we are communicating in plain language about the policies that we are developing so that the people who stand to benefit from those policies can understand them in straightforward language. We're also working on an anti-stigma campaign. Kelly alluded to it earlier. You'll notice that as a theme throughout. It is crucial that we destigmatize in our space. I also work to manage official internal and external communications. So I really encourage folks to go to the department website, check out our press releases there and our news releases. I also encourage folks, go to YouTube, search for NCDHHS, Department of Health and Human Services, and search for our mental health town halls. The secretary has been doing town halls across the state for about a year now, and that is a great place to go to hear directly from him, as well as legislative leaders throughout the state about these very important issues. Another part of the work that's happening in this section, we are doing a lot of planning and design work to enhance key initiatives in the division. And so 3 of those areas are peer support services, services for justice involved adults, and crisis services. It's slightly different. We're not managing the programmatic day-to-day part of that work. That's happening in Sarah's shop. But we're thinking about what are our opportunities to expand, to strengthen, to improve services in these areas? How do we design for that and build for the future? And I'm not sure who's up next, but we'll go to the next slide.
That would be me, Charles. Good afternoon, everyone. My name is Jennifer Mead, and I am the Assistant Director of Advocacy and Empowerment here at the division. And like others on our executive leadership team, as well as others in the division, I too am somebody with lived experience. I've been with the division now for almost 1 year. October 4th will actually be my anniversary, and I'm very excited to be here. Prior to that, I was in the LME MCO world, local management entity, managed care organization world for over 15 years. So here at the division, I have the privilege of working with 2 wonderful teams in my section. And the first of those is the Customer Service and Consumer Rights team. And this is the group that manages the Division of Mental Health, Developmental Disabilities and Substance Use Services call center. So this team fields thousands of phone calls a year and help consumers, family members, stakeholders, really whoever calls in with just resources, service access support, technical assistance, and any kind of general information. This team also oversees the state critical incident reporting process and system, which is known as IRIS. And ensures that all critical incidents involving individuals who are receiving publicly funded mental health, developmental disabilities, substance use, and/or traumatic brain injury services, that all those incidents are reported and addressed in a timely manner. And then that, last but not least, they also handle complaints and manage the state-funded appeals process. So the other team in my section is the Community Engagement and Empowerment team, the CEE team. And this team is responsible for the support of our State Consumer and Family Advisory Committee, otherwise known as State CFAC, as well as the oversight of the NC Peer Support Program, which Charles mentioned earlier on his slide. Our Veterans Liaison is also a part of this team, and that individual engages with our veteran serving agencies across the state and provides information about behavioral health resources and supports to our military and veterans population. And then finally, the CE team helps support the division in many of our outreach and educational opportunities. So I too have included our contact information for both teams at the bottom of my slide in case you ever need to reach us. Thank you.
Good afternoon, everybody. My name is Matt Herr. I'm the Assistant Director for Assistant Performance at DMH-DD-SUS. I have about almost 2 decades of experience in this field that ranges from direct care to research to working for Disability Rights North Carolina and then with the department. I joined the department about 6 years ago. I've been with DMH-DD-SUS in my current role for about 4.5 years. I also am a person with lived experience, both as a family member, and that's ranging across IDD, mental illness, or mental health, SUD, and suicide. I'm also a person with a disability. In fact, next month will be 11 years since I was diagnosed with MS. And so really happy to be, bringing that experience to the work that we do at the division. With respect to my actual position in the division, I'm sort of the lawyer, a friendly lawyer amongst clinicians. A lot of my teams handle the sort of regulatory aspect of a lot of the work the division does. So we have a team that oversees the division's contracts with the LMEMCOs and soon to be tailored plans. There's a lot of contract oversight, making sure we're ready to go for tailored plan launch. Quality management team is under me that does a lot of the data work for the division. Information systems oversees like the databases, so like claims processing and making sure that everyone's getting paid and we're collecting the data that we need to report to the federal government. I have compliance teams that make sure that money is being spent appropriately. Also, if we ever get any like fraud, waste, abuse allegations, that team would be looking into that. And then we also have a team that credentials providers that do DWI services. So if someone gets convicted of a DWI and they have like court-ordered treatment, they go to certain providers, and we are the ones who make sure that those providers are doing that work sort of within the law. So a lot of it, again, is sort of in the regulatory space, but my goal is always to make sure that the sort of legal landscape and all that, the complicated stuff behind the scenes is working as elegantly as possible in order to support all of the good services and supports that the policy folks are trying to enact and make sure that our sort of rules and legal bits are falling in line with all of the strategic priorities that the division has. I think that's all I got. Thank you.
Good afternoon, everyone. I'm so happy to be here. My name is Carrie Brown. I am the chief psychiatrist for the Department of Health and Human Services. And a little bit about me, I've been in North Carolina for over 25 years now. I came here for medical training and fell in love with North Carolina, and I'm very honored to still be here and have joined the department about 5 years ago. I have a couple of different roles at the department under the billing of chief psychiatrist. One is I am the portfolio lead for the Secretary's priority of behavioral health and resilience. And another one that you guys may be very familiar with is I also operate as the chief medical officer for our 13 state operated healthcare facilities. And as deputy chief medical officer for the department, I work very closely with our state health director, Dr. Betsy Tilson. And, I just think that this is, having been in North Carolina for a couple decades, I'm just so honored to be able to be at the department now. I think this is we've got a lot of work to do, but I think it's an incredibly exciting time in the world of mental health, substance use disorders, and intellectual and developmental disabilities, as well as traumatic brain injury. So happy to be here today, and I'm going to hand it off to Dr. McCoy to introduce himself.
Thank you, Dr. Brown. My name is Keith McCoy. I am a psychiatrist, just like Dr. Brown is, and I work on behalf of the department and on behalf of Dr. Brown in a few areas at DHHS. One is here at DMH DDS-US, where I partner a lot with our quality and policy and programs teams around the development and implementation of various clinical initiatives. And then I'm also at Medicaid. So I'm the Associate Medical Director for Behavioral Health at NC Medicaid, where a lot of my focus is around what's the services that our LMEMCOs provide, some of the behavioral health services that our standard plans provide, as well as ongoing development of new programs, including managed care programs like tailored plans, as well as what's newly legislated for the Child and Family Specialty Plan for kids and families involved in the DSS system, as well as updating many of our services that both DMH, DDS-US, and Medicaid co-design, along with tailored care management, which is our new, not that new, but since December, our primary care management platform for individuals with Medicaid who have serious mental illnesses, serious emotional disturbances, intellectual and developmental disabilities and traumatic brain injuries, along with severe substance use disorders. Like others, I also have lived experience myself, as well as lived experience with family members who have mental health issues. And it's an honor to work on behalf of the people of North Carolina. And at this point, I'm going to hand it back over, I believe, to Director Crosby.
Thank you very much, Keith. Thanks everyone for doing those introductions. It's a really great team here, and I'm honored to work with you all. Another key position I should mention, we don't have it because that role is not filled yet, is we do have a key position that just closed actually for a director of quality, evaluation, and analytics. So one of the things we're going to share at the end of today's webinar is our dashboard. One of our many dashboard, but this is a really critical one for us right now. But one of the things we want to be able to do in these webinars is to bring you data, but also make sure our website is sharing data with everyone about items that are really critical to our system, including how we're doing on our state mental health, substance use, IDD, and TBI plan. As Charles said, every single one of those letters is important. And I want to tell you what our state mental health, substance use, IDD, TBI plan actually is. So on the next slide, we are required by law, and we don't mind, we're glad, we're required by law to actually have a mental health, substance use, IDD state plan. Under 122C, we're required to have this. The last one we have is kind of old and dusty. I think it's about from 2017, we saw a draft. But why do we care about this? Why do we care? We care because we want to share a joint vision for the outcomes of our system. What do we want our system to accomplish? What do we want it to look like? We want to use this document to promote collaboration between all of us. We are all part of the system working together. So how can we collaborate together to get those kind of outcomes we want? How can this plan inspire change in our system? So we are looking for a system where everyone engages, everyone contributes, and we act. On the next slide, we wanted to share with you a super draft version of the priorities that may end up in that state strategic plan. Remember, I mentioned to you at the outset, we're going to use this webinar to kind of introduce big concepts, and we'll use those smaller provider, consumer, and clinical groups to really work through some of the details. So today we want to introduce at a high level this idea that we need a state plan that is collaborative, that inspires change, that envisions the outcomes we want for our system. And that starts with saying, what are our priorities right now in this time, in this system? We shared the departmental priorities. They're broad, they cover all of us, but we wanted some very specific for our mental health, substance use, IDD, TBI system. So these are draft right now. And what you'll see under these priorities, you will actually see goals. You will see metrics to say, are we on track? And then you will see strategic programmatic interventions. Where might we want to promote a new policy, a new program? Where might we want to invest some of our block grant or state dollars in critical programs that help us work towards these goals and these priorities? So that's what will fall underneath it. But first, we're just up in the priority space. Where do we think we are? So these are very draft right now, y'all, very, very draft. But here's where we are in our thinking around priorities, which we would like to unpack with you all in our stakeholder meetings. So first, prevent overdose and suicide. We know that our rates of overdose and suicide continue to climb ever since the public health emergency. We need to continue to make sure that people have access to preventative and evidence-based services, and that we're reducing those numbers. We absolutely need to promote choice and inclusion. So people with IDD, TBI, serious mental illness need to be able to choose where they live, where they work, the things they want for their lives. So supporting choice and inclusion is really important for us. We want to promote emotional health for children and youth. So we want to make sure that children are getting health and wellness services. They are getting out of the crisis system. When they are involved in the crisis system, they have services that meet their needs. We have the full treatment array for kids. Hopefully that's keeping them well on the preventative side, but in the event that there is a crisis or need for a high level of care, we need to make sure that we have access and that the services provided in that higher level of care are high quality and getting us the kind of outcomes we want, so kids are getting great outcomes. We also need to strengthen our workforce across the board. We know that. And we need some real measurable goals and some interventions in our workforce space. And lastly, we need to create a seamless crisis system. We've invested a lot in things like 988, BH Scan. But we need a lot more investment so we have a fully functioning crisis system in every part of the state. Someone to call, someone to respond, and somewhere to go. That is not law enforcement, that is not a traditional emergency department situation. So besides our strategic priorities, we want to make sure that we have guiding principles throughout. So as we sat as a leadership team, as we've talked already to some community members, these are some of the guiding principles that rose to the top. When we do this plan, when we do our goals, when we do our measures, we must consider equity at every stage along the way. We have to consider consumer voice every stage along the way. We have to, as much as we can, promote the adoption and use of evidence-based practices. We need a system that is trauma-informed for so many reasons. That's why we need our own crisis system that is responsive and trauma-informed, as well as the other services, supports, and preventative things in our system. And we need to think about quality at all times and use data to inform continuous quality improvement. So those were some of our guiding principles. Now remember, this is very draft. So in the next slide, we'll tell you where we are in terms of stages. So right now, we are just looking at the landscape of needs and opportunities. That means talking with you. That means looking at the data that we do have. That means talking to stakeholders, even with outside of our system, right? Law enforcement, DSS, and they are telling us issues that they feel where we need stronger or different mental health, substance use, IDD, TBI systems. So we're doing that landscape assessment now. We have also started to engage you all in routine collaboration. So this is part of that, introducing this idea for you that we need to put together a state plan that lasts, that's for 3 years, that's for 5 years, that is transparent, that is measurable. And then we need to develop that draft and then final strategic plan that has our priorities, our guiding principles, our goals, our interventions, and our measures. One that we can all agree on, and one that gives us something hopefully to work towards. So that is that's our next step, to engage with you guys in additional conversations around these priorities, but also goals and metrics. All right, on the next slide, I want to talk a little bit about the budget. We're going to do some budget updates. So on the next slide, the very first thing we want to highlight is Medicaid expansion. Today is the day to celebrate Medicaid expansion. Hopefully everyone has seen the press release from the governor and from Secretary Kinsley, from our wonderful Medicaid team, some of which who are on this call today. We are really just celebrating Medicaid expansion after so many years. And a special thanks to the Medicaid team, others within the department, others within the General Assembly, and you within the community have been such strong advocates for Medicaid expansion. So thank you for all of that work. This is a once in a generation opportunity to support people with healthcare, behavioral healthcare, substance use care, supports for families with intellectual and developmental disabilities and traumatic brain injury. When Medicaid expansion launches, it will provide healthcare to 600,000 more North Carolinians. And that means more mental health, substance use services, more IED and TBI supports for those who are eligible for Medicaid. It also means it frees up state dollars. We will always need state dollars to pay for folks who continue to be uninsured or to pay for services that Medicaid is not able to cover. But as people do move on to Medicaid, very exciting, we will be able to think about how we use our state and in some cases, federal block grant dollars in new and exciting ways to even increase our coverage. So today is a wonderful day to celebrate Medicaid expansion. On the next slide, and you're going to see a release come out about this very soon. And I'm grateful to this. And you saw Dr. Carrie Brown, such a champion in this space. We have gotten unprecedented numbers of dollars for mental health, substance use, IDD, TBI investments in the budget. Unprecedented. We're going to release something that gives all of the things that we got funded and how much money it was truly extraordinary. If you remember, the governor put out a $1 billion reinvestment in behavioral health and resilience plan. At least 2/3 to 75% of that plan was actually funded in the budget. In his base budget, he asked for things like direct support professional increases, wage increases, innovation slots. And then he had a separate spending plan for behavioral health. A lot of those were funded, which is truly extraordinary. And I'm very grateful for the governor's leadership, for Secretary Kinsley's leadership, for Dr. Carrie Brown's leadership in this space, my boss, Chief Deputy Secretary Mark Benton's leadership in this space. And I'm appreciative for all of you for your partnership in helping us get these kind of unprecedented levels of financial support. So let me just give you a high-level overview of the things that were funded. First, behavioral health rates. We got increases to raise behavioral health rates that haven't been raised in a decade. We desperately need them. We get what we pay for. Behavioral health services are so very important. All of you who provide mental health, substance use services, you change lives. It is profound. It is not easy work, and you should be well compensated for that. So I'm particularly excited about behavioral health rates. We also got funding to increase collaborative care and NCPAL. So very upstream work. How do we make sure that we're embedding mental health services in primary care and also using scarce psychiatric resources to support primary care offices and schools? So super cool that we got funding for that. We also got workforce investment, lots of them. We got direct support professional wage increases. We got $10 million for a behavioral health center of excellence. We got money for DSOF because we have about 300 beds we're not able to open right now in our state facilities because we can't afford workforce. So now we'll be able to afford more workforce. And we got an additional $10 million in loan forgiveness programs for licensed behavioral health professionals. So a wide variety, where we'll be able to support direct support professionals, unlicensed professionals, licensed professionals. So super exciting. We also got, I believe it was $100 million for justice programs. Those are diversion programs, reentry programs, and capacity restoration. And these are for folks with mental health, substance use, IDD, who are involved in the justice system, but really need treatment services and supports. We got about 80 million, I believe, for crisis systems. So we can invest that in mobile crisis, facility-based crisis, urgent cares, NC START, respite, non-law enforcement transportation. That was a separate pilot. So that's really exciting for us. We also got a pot of money for child well-being, and that can fund everything from family models of peer support to specialized PRTF services that we need here in state, to crisis stabilization beds and crisis facilities for children. We also got IDD innovations slots. We got authorization for Medicaid to expand the TBI waiver statewide. Now we need some funding and slots, but we got approval to look at it. And we got $10 million for competitive integrated employment. To get more inclusive workforce. Hopefully folks saw our announcement around Inclusion Works. We want to make sure people with intellectual and developmental disabilities, serious mental illness, have access to career coaching and options and can work in the most integrated setting for a fair wage and fair benefits, just like everyone else. Integrated workplaces are good places. So again, so much investments. And the reason that we're going through all of these today is because, again, in this large space, as we think about how to use these dollars, we want to bring that to you and talk about how we intend to use these investments. And we intend to workshop those in our smaller groups, as I mentioned before. So unprecedented. These things will all factor, of course, heavily in that state plan that I mentioned, right? So the really cool thing is that we'll be able to put together a state plan with funded interventions that we hope make a real difference in our system. Next slide. I'm going to do a quick update to say you can put questions in the chat. We might not get to them all today, but feel free to put your questions in the chat and we will try to answer what we can. So the last thing I wanted to cover today. So we talked high level, we talked about the purpose of these webinars, we talked about departmental priorities, putting together our state plan. We talked about all the funding that's going to be coming into our system in the next 18 months, which is truly extraordinary. And the last thing we wanted to highlight today is our LME MCO dashboard. We have already shared this with you. We've been publishing it since April. The LME MCO dashboard is a department-wide dashboard. So it's not just DMH DDS US, nothing of what we do is just us. We do everything in partnership with our department partners. So this is a dashboard where we're getting data, and we got input from Division of Child and Family Wellbeing, DSS, our state-operated healthcare facilities, health benefits, our Medicaid team, and of course us. It's a big partnership here to talk about the metrics that matter most to our mental health, substance use, IDD, and TBI system. So the goal was just to have a tool that highlighted areas of shared priorities and to show us and you areas where we have opportunities to improve. We feel like if you shine a light on issues, we can work collaboratively to solve it. That report, we have a link here for where this dashboard is published every month, and you can see the old reports as well. I want to give a shout out, it's not on this slide, but I want to give a special shout out to our LME MCO partners. Data is tricky, it's very tricky, y'all. And data is something to investigate. So when you see the dashboard, these are the conversation around the data and what the data means are conversations we've been having with our LME MCO partners. So we appreciate them. We appreciate you as providers who also are part of solutioning some of these issues. And we appreciate in the feedback we've gotten so far from consumers and families around, are these the right metrics that need things to our system? So here's where we are now. It's first phase, and we look forward to refining this dashboard over time. So there's 5 measures, and I'm going to use the first measure to kind of orient you to what the dashboard looks like. It's busy, y'all. So if you can go to the next slide. Okay. So I'm going to tell you about the first metric of 5, but I want to use this as a way to orient you to all the dashboard metrics. So on the left-hand slide, what you're going to see is you're going to see some kind of comparator. So it's either going to be gray bars, or in some cases, you'll see a pie chart. So all LMEs are different shapes and sizes, right? Some have many different populations, right? Different populations. So we are trying to set some sort of standard, normalized standard on the left-hand side. So this particular measure is about Medicaid children in emergency departments and DSS settings. So right now we have a shared issue, it's very joint across all of us across the state, that we want children to receive timely, correct treatment in the right and appropriate clinical setting. So this measure is telling us, okay, where things might not be working entirely the right way, right? A lot of factors involved in that, right? So these are children who do need some level of treatment, but are waiting for that level of treatment. It could be PRTF, it could be another level of treatment. They're waiting in either in an emergency department or they're waiting in a DSS setting. So on the left-hand side, we look at the number of children per 10,000 children. So we tried to normalize across the LME MCOs, right? On the right-hand side, you see the metric broken down, and you'll see the same for every metric. You'll see the measure broken down by each individual LME MCO. Across the bottom, you'll see the total. So you'll see 36, 10, 11, 15, 11, and 14. And again, very different population sizes, which is why you need the gray bars on the left-hand side to sort of compare apples to apples across the LMEs. And in the bar charts, we've stratified the data. So when you look at alliances, you see 36 children, but we wanted to separate that out from children who are in emergency departments not involved with DSS, children who are in emergency departments and are involved with DSS, so they're DSS involved. And then lastly, children who are being housed or waiting for treatment either in DSS offices or hotels. So I spent a little bit of time on that because I wanted to be able to use this as a way to illustrate how we've created these dashboards. On the left-hand side, you're going to see kind of a key, so you can compare all the LMEs to one another. And then you will see on the right-hand side, usually a bar chart, where we show data specific to each LME, and we also try to break the data down into subgroups. So this is an important measure to us, I think all of us, right? And we know it's affected by quality of services, availability of services, rates we're able to pay in our behavioral health system. It's affected by treatment foster care, the availability of PRTFs in the state. So there's a lot of factors, right? Interestingly, a lot of things we were funded for to try to tackle this issue, but it's an issue. So it's a good metric to watch for all of us. All right, next slide. The next one is the number of Medicaid children in PRTFs. So sometimes children need a very complex level of care. When children do need that PRTF level of care, we want them to get the best treatment that meets their needs, of course. Sometimes that's specialized. And we also want them to remain connected to their community supports, be it their family, whoever, as much as they can possibly be. So again, we're looking at the number of children in PRTF. So on the left-hand side, you see the comparison of each LME MCO. That's a normalized number. That's the number of children per 10,000 that are in PRTFs. And on the right-hand side, this is pretty tricky. But we wanted to be able to look at the data to say, is the child involved with DSS or not? Is the child in an in-state PRTF, a border state? So it means they're close to the border, right? A lot of kids who live in Mecklenburg, maybe in South Carolina, because that's actually closer to them than going over to Wilmington. Or is the child actually beyond 40 miles out of the state border? So they in a totally different state like Alabama or Utah. So that's how you can read the right-hand side. And the arrows say, is this trend going up or down? On this one, of course, we want children who need to be in PRTF and PRTF. Overall, we would like to have more children in preventative upstream care than in PRTF. And certainly we would like them to be as close to home as possible. So this is one where we're looking for hopefully all of this to go down. Number of kids to be in PRTFs to keep going down, and certainly the number of kids way out of state to be going down. All right, next slide, please. So these are folks who are in a state psychiatric hospital who are ready for discharge. So what does that mean? Someone who has completed their, and we know the highest level of care that we have are our state psychiatric facilities. I mentioned at the top of the hour that we have not able to have as many available beds. We have staffing shortages in our state facilities. And it's really critical with the reduction of beds that people who are ready to go into the community are able to go back into the community so we can free up beds. And that's really challenging, right? A lot of people coming out of our state facilities need a lot of wraparound supporting with housing and other services. On the left-hand side, you will see that about 27% of people in state facilities are waiting for discharge. So they're ready. They don't need that level of care anymore, but they do need additional community supports. On the right-hand side, you will see by LME the percentage of people who are in their catchment area who are waiting to be discharged versus those who are not ready for discharge. So we'll see in some cases you have some LMEs that are below that state average of 27% and some that are above. And again, every place is different. Housing resources and services are different every year. But again, people who do not need this high level of care, we don't want them to be in that level of care. We want them in the community, integrated in the community in a way that makes sense for them. And we also want to free up those beds. So this is one we're looking for the number of people ready for discharge to actually go down. We want them to be ready, but we want them to actually be discharged. All right. And the next measure is specific to the Innovations Registry of Unmet Needs. So people are waiting. We have over 17,000 people right now in the Registry of Unmet Needs. That differs, of course, by LME MCO. Some have lots of people on the waiting list and others don't, but that really is a question of oftentimes geography, but sometimes it's also families who know about the list or not. We really want people who are waiting on the Registry of Unmet Needs to be getting services. So this measure looks at the number of people on the Registry of Unmet Needs who are getting any Medicaid or state-funded IDD or behavioral health, so mental health or substance use service. Right now, about a third of people statewide, 35% of people statewide who are on the Registry of Unmet Needs are getting services. That means 65% are not. So if you look by LME, you will see the percentage of people at any particular LME who are on the wait list who are getting services and those who are not getting services. And again, this is a really tricky one. What's a really cool thing about this, though, is we have Medicaid expansion and we have the 1915I option. So we hope that that means more people on the waiting list will get Medicaid. Doesn't mean they all will, but maybe more will. And it also means that now with the 1915I option, more people are going to be able to access services like community living supports, like respite, like supported employment, like tailored care management. So we're very excited about watching this metric change over time. But our goal is that as many people on the run who are eligible for Medicaid services can get them. And if they're not eligible, how can we use state dollars to try and meet their needs as well? And here's our last metric. It's the busiest slide, I'll tell you the truth. On this one, we don't have a key on the left-hand side, but we do have a line. You see the line across both the mental health and the substance use? That's our target. So this is about timely follow-up for community services after someone is hospitalized for a mental health issue and when someone is hospitalized for a substance use issue. Obviously, we know that when people can get connected to services after hospitalization, they have a much higher chance of not going back into the hospital, of course. They have a much higher chance of engaging in treatment, getting their medications if appropriate. And it is an important critical stage in their recovery to get connected to community-based services. So on the left-hand side, you're going to see for those folks who have had a hospitalization for mental health reasons, the percentage of folks on Medicaid, which is the blue bar, or who don't have Medicaid, so who get state-funded services in the green bar, who get follow-up. Our state standard is 40% of people who are discharged with Medicaid and state to get timely follow-up. And so you see in that case, there's differences in how we're able to meet that goal across LME MCOs. On the right-hand side, of course, is our substance use, hospitalization and subsequent treatment after discharge. So again, the state standard is 40%. That's that dark green bar going through. And you see a real difference between Medicaid and state funds. Folks who are able to get care 7 days after discharge. So again, this is another area where we hope that Medicaid expansion can impact. More people will be eligible for Medicaid follow-up. So that's what this particular measure is. So on the next slide, one of the things that we wanted to create for you, and remember the recording of this webinar as well as the slides will be available after on our website. And one of the things we wanted to leave you with was resources. So if you go to the next page, one of the biggest resources we have right now for everyone in the system is 988, which is our suicide and crisis lifeline. It's chat, call, and text 24/7. We'll come back. We're actually going to we're past our 1-year anniversary for 988. We have so much data to share. We're looking forward to putting those dashboards on our website, but also sharing them with you. We're learning a lot of things about people who are calling 988. There's also resources to find treatment in the area. That's a national findtreatment.gov. North Carolina is on it as well. We also have our link for submitting questions to us. We want to remind folks about NC Care 360. So those are just some critical ways to reach us. As a reminder, go back to Jennifer Mead's slide. We do have our consumer resource line, our consumer call center that people can call at any time for support. On the next slide, just want to remind folks that here's how you can send questions to us at any time. And that is the link where we will record these presentations and these slides. So to go to Q&A, and I'm going to ask my teammates to turn their cameras on. And Charles is going to let us know if we have any questions. I haven't been watching the Q&A, so Charles will let us know.
Thanks, Kelly. Since we've been talking about LME MCOs, going to ask one of the questions specific to that. I'm just going to ask it in the language of the question itself. It has been very difficult to capture useful and timely data, both across the state and even within individual LME MCOs, for accurate information on who is being served, in addition to many other categories. What is being done to improve this?
That was a really big question. And there's probably many ways to unpack it, right? And it could be that folks are trying to understand very specifically about very specific services. One thing that we are doing is trying to make our website more accessible and also our data more transparent. So people probably don't realize the amount of data that we publish, and Medicaid publishes too, that tell about everything from like the number of people on the innovations waiver to the number of people getting a variety of different services. So we publish some of that data. Medicaid is getting ready to publish their waitlist information too, which I think is really exciting. I mentioned that we'll be publishing our 988 data soon, our behavioral health scan data, which tells about bed availability and also bed shortages. We're publishing this dashboard, but I think one of the things that we want to hear is we're trying to do better to publish the kind of data that's meaningful to you is to get that kind of feedback. Like, what are the most meaningful things that you think like the public needs to know this kind of information? Please use that link to let us know, like, this is the kind of data I'm actually talking about. But we are working to revamp our website so people know how to find the data that is actually published, but also, you know, revamping some of the things that we are publishing, because we want the kind of data that you all need to see out there. A team, if there's anything you want to add to that, feel free.
All right, Kelly, mindful of time, I will jump to another question. And this person says that they're very interested in the 2 education / anti-stigma campaigns that were mentioned. How can one learn more and get involved?
Want to take that, Charles?
Sure. So we are very much in the early stages of each of these campaigns. Part of what we have heard as feedback is that people do want to be engaged early and hopefully as often as possible. And one of the reasons we have created this webinar and that engagement structure that we saw in the slide earlier is to try to direct people to the right spaces to sort of maximize the impact of the discussions that we can have. So this will be one space where we discuss these campaigns, but I would definitely recommend connecting with your Family and Consumer Advisory Council, your local council if you have one, or the state council. That's going to be a great place to lift up your voice as a consumer. It sort of depends on where you sit. The Providers Association meetings is another great space, or if the LME MCOs are the place where you sit, that meeting. So we're trying to figure out the right scope. Would that we could make everything plain language. It's a very complex, complicated set of systems. We are just at the beginning stage, very excited about it. It's very promising. It will take thoughtful engagement, and we look forward to doing that with y'all in this space and in our dedicated stakeholder meetings.
I would add, I know Charles said this, but CFAC meetings are public meetings. They have public comment time, and we'll be going through portions of the campaign absolutely with our State Consumer and Family Advisory Council. So if you don't know how to reach those, look on our website. It'll tell you how to we'll tell you when the CFAC meetings are and when you can come. If you're a provider and you're like, hey, I don't even know about your provider meeting, send us an email. Just send us an email and we can add you to the provider list, because then those are really the places where we're getting, hopefully, have really good discussions and get a lot of feedback on this campaign.
Thank you, everyone. We are at time, so if we did not get an opportunity to answer your questions during the webinar, questions and feedback are welcome at the behavioralhealth.helpcenter@dhhs.nc.gov email. The recording and presentation slides for today's event will be posted on our community engagement and training webpage. The link has been included to the chat. There will be a brief survey following today's webinar, and we would appreciate your time completing the survey. Our next side-by-side webinar is scheduled for October the 23rd from 2 to 3 p.m. This concludes our webinar for today. Thank you for attending.